Good afternoon, everyone, and welcome to the third session in our palliative care webinar series, an overview of organ and tissue donation. My name is Emily Buchanan, and I'm the Primary Care Projects Lead here at Western Victoria Primary Health Network. And I'll be your facilitator this afternoon for this webinar. The Palliative Care webinar series is brought to you by Barwon South Western Regional Palliative Care Consortium in collaboration with Western Victoria Primary Health Network. Palliative care service providers from across the broader Western Victoria region are welcome to attend. I'd like to begin by acknowledging the traditional custodians of the lands on which we meet from today. I'm here in Geelong on beautiful Wadawurrung country. I would like to pay my respects to elders past and present and extend that respect to any Aboriginal people who may be present today. And next, just a little bit of housekeeping. This webinar will be recorded and you'll be able to access the recording freely on our PHN Learn YouTube channel. We'll put the link into the chat for our recorded webinar events, which you will be able to access. Please see our upcoming events in the Palliative Care webinar series on the screen now, and we will add the registration link to the chat. Just to note, we're in the midst of rescheduling session 2, which needed to be cancelled due to presenter illness, but we will be setting up some new dates for this one shortly. You may be, if you've entered the webinar not displaying your accurate first and last name, or if you're tuning into the webinar in a setting with a group of people, please put your full name into the chat box. Only our administrators from Western Victoria Primary Health Network will see this, but this will ensure that we can issue you with a certificate following the event. For this webinar, all participants will remain on mute, and if you have questions, please type them into the Q&A box and I will ask them to the presenter on your behalf when we get to the Q&A session at the end. Finally, there is a link in the chat box to complete the survey following this webinar, and we'll show this slide again at the end. Thank you. So now, without further ado, I'd like to introduce our presenter for today's webinar. We have Jo Cantianis, Nurse Donation Specialist from Barwon Health and Donate Life. Over to you, Jo.
Oh, thanks, Emily, and thank you everyone for having me. Okay. So yeah, as Emily said, my name's Jo and I'm the donation specialist nurse here at Barwon Health, and I work very closely with the ICU and ED teams to help facilitate any donations in the Geelong region. So today I'm going to cover just an introduction to organ and tissue donation, and hopefully, yeah. And I'd like to begin by thanking all of our generous donors and their families who have transformed the lives of people needing a transplant through organ and tissue donation. Without their generosity at often the worst time of their lives, that we wouldn't be able to do what we do. So we thank them. Just a bit of an overview of what we'll talk about today. I'll talk a little bit about just organ donation and the context of that in Australia. What organs and tissues can be donated, any exclusions. We'll give a brief overview of donation and particularly how a lot of the patients that are referred to us through palliative care would donate, and I'll share some donor stories as well, and some case studies. So the Donate Life network came around in about 2008, 2009, and it was started when Kevin Ruddle was our Prime Minister. We've had many since him, but and it was brought about because it was sort of found that we didn't really have an overarching group that would organise, and every state and territory did their own thing on donation. And so the Organ and Tissue Authority was born, and part of that was placing specialist nurses and doctors within hospitals throughout the country. And we now have 90 of those Donate Life Network hospitals around Australia with dedicated nurses and doctors. So here in Geelong, we have 2 nurses. Megan Bruns is our other nurse, and also Dr. Paul Power, who's one of our intensivists, who's our medical donation specialist here in Geelong. And we have 19 hospitals throughout Victoria. And our role is to really champion organ donation and ensure that all patients that are at the end of their life, either in the ICU or the ED, are having the chance for donation to be explored. And what we've found over the years after these implementations is that, yeah, we're getting a lot more referrals from the community and from the wards. And some of the donations we wouldn't have done in the past, we are actually able to start doing now, which has been really great. I think one of the most important things that I share with people is how rare organ donation is. It's an incredibly rare event that happens a lot less than I think people would understand. And I'll just show you this short video. I think it's a really great way to show you how rare it is. Bear with me. So I think that shares a real powerful message of how rare it is. But I think also just to note that here in Geelong in 2023, we only had 7 people that were able to go on and become organ donors from Geelong Hospital. A few others that were commenced the workup for organ donation but were unable to proceed, generally due to finding something that deemed them medically unsuitable. So it's incredibly rare that we have the donors and that we get to meet with these families as well. Oh, sorry. So just a snapshot of the donors in Australia in 2023. So we had, like most things, a bit of a slump during COVID. And a lot of our donor programs actually almost halted completely. And we've just been slowly building those back up the last couple of years. And 2024's at the current donation rates are quite high, and we're looking like we'll probably get back to that sort of 550 mark of 2019, which is great. It means that we'll definitely get those donor numbers up. So a lot of people ask what organs can be donated, and even though these organs have some age limits on them, it's important to remember that these are just a guideline, I guess. They're not definite, and at times that the age limits can be pushed a little bit depending on recipient needs and how well perhaps a donor was. The main ones, I think, we do are the lungs, kidneys, liver, and heart. Pancreas occasionally. The donors need to be pretty well for a pancreas and not have suffered any sort of ischemic time or hypovolemic time. And a stomach intestines is also very rare, and we generally only have 2 to 3 people waiting for that a year. And we need our donors for our stomach intestines to be quite small, as our recipients are generally really unwell with intestinal issues, and so are really small people. Yeah. So organ donation, I guess, is what we spend a lot of our time trying to do. One of the really great things is that if organ donation isn't possible, that for some people, there's still the possibility to donate their eyes and their tissue. So we can donate cardiovascular tissue, bone, skin, tendons, and eyes. And a lot of the bone and tendons is used for reconstructive surgery, especially for traumas, or for people that have had to have bones removed due to cancer. So skin's used a lot for our burn patients, or again, if needed in reconstructive surgery. So cardiovascular tissue is generally heart valves and eyes. So the corneas are donated to restore sight, and they use the sclera, the white of the eye, which helps again in reconstructive surgery. So they often use that if they are doing a prosthetic eye. They use the sclera now, and it's actually really difficult to tell the difference between a native and a prosthetic eye. So exclusions to organ donation. It's one of those things that, again, in the past, we would have said some of these things were absolute, but as time changes and as our recipient pool gets larger, that these aren't all such absolute exclusions now. So HIV, we do have a HIV recipient population, and so we now can accept HIV donors who will donate to that recipient pool. As metastatic cancers are still an exclusion, but again, it depends on the cancer, where it's located, and what we deem the risk to be. So we follow the T and ANZ guidelines for that, and they will help us decide whether or not we think the risk is suitable or not. And then CJD or mad cow's disease again. So this is just on if there's any suspicion of mad cows, then unfortunately not able to donate. And COVID-19 was an exclusion of active disease. And now some transplant teams are still saying no to donors with COVID-19, but less and less so. So it's not an exclusion completely anymore, which is great, as we've understood a bit more about it and its impact on other organs other than the lungs, that it's definitely not causing us too many issues now. So for donation to occur, the patient needs to be dead. And we have 2 pathways that people can donate down, and that's either following neurological death or brain death, or circulatory death. So, which we call DCD, or donation after circulatory death. And both of these definitions are death, and the patient is legally deceased. So neurological death with brain death, often they're declared brain dead early in the piece, and it can be in a couple of days before they're taken to theatre, but they are kept breathing and their heart beating on the ventilator until they go to theatre. And circulatory death is probably the more common, and what most of our palliative care patients will donate following is via circulatory death. And it's just that we withdraw care in the ICU and the patient's allowed to die in their own time, and then they donate following that. One of our big things is that the family care and donation are not competing values, and we believe that, you know, discussing donation and offering donation is a really important part of end-of-life care, and it should be included in all end-of-life discussions. So a lot of my job here in Geelong Hospital is meeting with all of the families whose loved ones are at end of life and talking about organ donation, much the same as we talk about any other values or beliefs that would be important to the patient or their loved ones at that time. So there we see that they're not a separate thing, but something that can happen really lovely together. In 2018, the Victorian government sort of recommended that all patients are referred in the ED and the ICU. And the big part of this was to check the Australian Organ Donor Register. So we have people in the community taking time to register what they want, and that if we weren't checking this, that we weren't ensuring that we had covered all of their end-of-life care wishes. And also by referring to us, it enables us to undertake medical suitability and see whether someone is able to be a donor or not. So we ask the ICU and ED teams in particular to get in contact with us as soon as they think a patient's moving to palliative care or futility's been confirmed, and we work very closely with them to get things happening. A big part of my job is asking people to register to the Australian Organ Donor Register, and we do that because we know that it makes that decision for these families a lot easier. They've been asked a question at the most horrific and worst moment of their life when they're told their loved ones has died or is going to die. And if they know what their loved one wants, it makes this a lot easier. Apologies, I'm in the hospital. There's about to be an announcement. So we know that 8 out of 10 families will give consent when they're aware of what their family wanted and they were a registered donor. 6 out of 10 is if they've maybe had a discussion with their family member and they knew that's what they wanted. And only 4 out of 10 will give consent when they are not registered and they're not aware of what their loved one would have wanted. So it makes a really big difference in our consent rates. As part of what we do, so we follow up at Donate Life all of our donor families. We follow up with them and we often send out a survey, and part of the survey was asking the question on the main reason that people decided to agree to donation. And for a large part, it was that something positive has come out of a personal tragedy. Other things that people said was that someone else could live a better life, that they wanted to help other people, that part of their loved one, of their person, would live on in someone else, or that they indicated their wishes, and often even just that they've known a recipient or a donor in the past. So I'll touch a little bit on how we determine circulatory death and how someone will donate down that sort of pathway. So what we do is we withdraw cardiorespiratory support in the ICU. We do it, that's normally done by the intensive care doctors, and they do it as they normally would. So whatever medications or treatment they give at that time, they do it without any input from us. A big part of it is that the patients need to die within 90 minutes for donation to proceed. And that's because the ischemic time to the organs, that we just often can't wait more than that because the organs become too damaged. So once the patient's lost output, we have a 5-minute stand down time, and we watch the monitor for 5 minutes, make sure there's no auto restart of the heart, and then at that point declaration of death is confirmed, and we move straight to theatre. So the family have, from the time the heart stops until we go to theatre, that 5-minute stand down, and then we go quite quickly around to theatre and commence the donation operation. We spend a lot of time with our families in our consent discussing this part of it, and ensuring that it's something that they're comfortable with, and they can, and really making sure they're aware that they can come back and spend time with their loved one after their donation operation. So it all happens quite quickly, and we often find, rather than people being upset by this process, that they're often asked at the 3-4 minute mark, just go to theatre. They are really invested. They want that the best outcome for the recipients, and they do. So we often have to push back and say, no, we really do need to wait that 5 minutes. Let's go back. So I've got a couple of case studies to share with you, and hopefully, if I'm running okay for time, we'll get through both of them. So they've both were slightly different cases, and presented differently, but both were referrals from advanced care planning teams. So the first case is a donation following voluntary assisted dying. And this patient was a 66-year-old female with motor neurone disease, and we received the referral from the advanced care planning team. She was a lifelong non-smoker, and at that time was applying for voluntary assisted dying. So from a Donate Life point of view, our policy and procedure is that we won't get involved or speak to any of the patients accessing VAD until their permit has been received. So that permit was received in March, and myself and Megan arranged to meet with the patient and her husband in their home. We went out and got to meet and have a chat and let them know about what the donation process would look like. We did the consent paperwork with the patient themselves. We, for all our donors, we complete a health questionnaire, and it's normally with their next of kin. In this case, we're able to do it with the patient, and we just plan further tests as an outpatient. So a big part of the workup is to ensure that the organs are safe for transplant, and that they don't have anything medically that would mean that they're unable to be transplanted. Our next step was obviously to engage with our hospital executive, who have been on board from the very beginning with all of our voluntary assisted dying cases, and ICU director, our ICU nursing manager, our donation specialists, and also the medical imaging team here at Geelong, as they were the ones that were going to be doing all of our pre-workup scans. So we offered the patient to either be admitted the night before, actioning her VAD, or we could do the workup in the weeks prior, and she chose the week prior. So she came in and had a CT scan. We did chest, abdo, pelvis, and we were looking at the lungs and the liver and the kidneys and just making sure that there was nothing sinister, but also just that there was nothing that would preclude donation. Chest x-ray, we did a full set of bloods, full set of observations, and sputum and urine specimens were sent home. And we also at that point started to do our routine bloods for donation, which is a lot of our cross-matching and sort of just your routine serology tests. So everything went really well. That was a really great, smooth process, thankfully. And a few days later, we went out to their home again, collected any specimens that were outstanding, and we just spent a lot of time talking about end-of-life specifics and arranging the plan for the day. Obviously, these patients are often had planned for their end-of-life care to be quite different to what it's going to be. So this patient had wanted to die at home, in the presence of her family, outside under her favourite tree if possible. And then we have asked that if she was to become a donor, that she comes into a very clinical building, into the intensive care unit, and die in a very different way. So we spent a lot of time discussing what we could do to try and bridge that gap a little bit. And we found a room with a view, and they had some specific requirements around wanting to have a glass of champagne and family and music and other things. So we made sure that all of that was organised and made a plan for admission on the day. So 5 days prior to the VAD, we made sure we had some organs accepted, and they were lungs and liver, and her eyes were going to go to the motor neurone disease research program. And we try to get these organs accepted as early as possible so that we're not bringing patients in if there isn't anything that's able to be donated. The day prior to it, we had our kidneys accepted, which was very exciting. So at that point, we had 4 organs for solid organ transplant and eyes to research. So the day of donation, the family arrived to ICU and the patient at about 11. We let them get settled in. We put into cannulas, took some bloods, COVID swab, as always, and ID pans placed. The VAD physician arrived. The patient's extended family arrived. At this point, the family really wanted information, and the patient, about what organs had been accepted, and there's a little bit of information about the recipients. So we were able to share that there was to be, at that point, 5 recipients. So the lungs were going to be separated, and the left and right one to be transplanted into separate recipients. And her smile when she knew how many people she was helping was, it was a very humbling and amazing moment to be able to fulfill this wish for her. So we have what we call a DCD pre-meeting, and we do that so that everyone's aware of their roles and what they are meant to do when it's time for the donation to go ahead. So we do that with the theatre teams, with the surgical team, with the ICU teams, and in this case, the VAD team. And then we came back to the ICU. Everyone did what they needed to do, and at 2:35 p.m., which is where we, with Donate Life and members of palliative care teams, have decided that the withdrawal of cardiorespiratory support would be equal to when the completion of the medication has been administered. She had loss of circulation 6 minutes later, declaration of death 5 minutes after that, and was in theatre having the donation operation begin shortly after that as well. So it all went incredibly well. And the ICU did a beautiful guard of honour, that she was walked to theatre with her husband and her children, and yeah, it was a really, really beautiful day. And the donation outcomes were phenomenal. So she was able to donate a left lung to an adult female. She'd been really unwell prior, been waiting many, many months and up to a year for a transplant. So that was a really great outcome for her. Her right lung went to an adult female, and she'd also been struggling with just really simple tasks prior to her transplant, and she's recovering really well at home. Left kidney went to a young adult male, and he'd been on dialysis for, I think, 3 or 4 years. So again, another really great outcome for him. The right kidney went to an adult female, and she's also been discharged home and doing really well. For most of our livers that are donated via the following circulatory death, they've put on, the Austin have a very special machine called the Organox, and they put the liver on it and they see how it perfuses and metabolizes. They can do bloods and gases and all sorts of things on it. And unfortunately, there were some ischemic issues with that, so that wasn't transplanted. But her eyes did go to motor neuron research as well. So a really great outcome. And we've spoken to her husband and family a few times since, and they are very incredibly proud of what she was able to do, knowing that her outcome wasn't going to change, but that she's been able to save the lives of these 4 people. So the next case study is a little bit different, and some people may know or have heard of this case before, or been a part of it even. Again, another extremely rare and amazing process to be a part of, that I feel very privileged to being able to do for this gentleman. So this gentleman was a 60-year-old who had a grade 4 GBM, some history of hypertension, asthma, cholesterol, and a distant ex-smoker was what I was told, and there was queried some past heavy ethanol. Again, referred from the advanced care planning team, and that we were told at that time that the donation was really important to the patient, and that they were a current inpatient on the palliative care ward. So this was around in March. So we spent a lot of time talking about the risk of transmission from a GBM, discussed with our specialists at Donate Life Victoria, and in consultation with our TSANZ guidelines, it was decided there was a less than 2% chance of transmission risk, and that at that point we would continue to explore donation. So I went and met with the patient and their daughter in the palliative care ward, and he shared with me that he'd been a long-time blood donor, and this was really something that was important to him, that he was going to be able to continue to help people after his death, that he really didn't want people to go through what himself and his family were going through if he could help. So I discussed with them both what the DCD donation would look like. We filled out our health questionnaire, and again, he gave his consent for scans, x-rays and bloods, with the full knowledge that these scans would potentially show something that meant donation couldn't proceed. In early April, I wasn't aware at the time that he had applied, but he had VAD approved for self-administration, which didn't really change anything for us. We were just continuing as we were. His bloods and scans were all within normal limits, and we went to early organ offers, and we got lungs accepted quite early on, so we were able to proceed with the case. Obviously, in this case, the patient was in a different location, and for donation to occur, we were going to have to move him over to from the palliative care unit to Geelong Hospital. So we didn't want to do all of that if we meant that that donation wasn't possible. Again, we discussed with all the hospital executive, medical, nursing managers, and this is probably a bit more this time because we were recovering also a palliative care unit and all the palliative care team, as well as different hospitals, and also trying to find a team who we could admit him under once he came over. But everyone was very supportive, and we pushed forward. The patient let me know that he had a VAD date in his head of late August, and this was still April. His dexamethasone had been completely weaned off, and so we all felt it was unlikely he would make that date, but we proceeded with the knowledge that that's what he was aiming for. In mid-April, we did all the formal consent and paperwork was all signed off. And at that point, we also put out renal offers. And we had a South Australian recipient that accepted a kidney. And they were very aware of the case details. They were clear there was an unknown donation date. This recipient was one that had been waiting for a very long time and had a lot of issues in receiving a donor kidney. So it was pretty much a 1 in a million chance for this recipient. In late April, we had lots of discussions and education between all the teams and plans put in place on how to manage and how to transfer the patient over when the time came. Obviously, we weren't sure what his trajectory would look like in regards to his disease progression. In the first week of June, the decision was made by the palliative care team due to increased confusion, hallucinations and seizures that he was no longer able to make the decision to action his voluntary assisted dying, and his permit was removed. And then again, I guess we had to change things up a little bit at that point. VAD gives us the time frame and makes it quite an easier process for donation to occur. We can get everything lined up. But we knew how important donation was to him. And so we still aimed to transfer when he got to a point of deterioration. And I think everyone was very aware that there was a very big possibility that donation would not proceed. But we all just kept going and hoped for the best. So in early July, we got a call to say that he had deteriorated. His family were a little bit concerned about donation and transfer. And we spent a lot of time with them trying to get to the bottom of it and what their discomfort was. And really it was around causing him distress on the transfer. So we made a plan with ICU and us at Donate Life to ensure that that was a really safe and comfortable transfer. We let the family consider things overnight and we re-met in the morning. The next morning they were comfortable for donation to proceed. And we really spent, again, more time just saying that his comfort was our priority and that we would be with him throughout. So myself and the patient travelled from ambulance from Grace McCullough to Geelong Hospital ICU, where he was admitted. He did have some periods where he was awake, but he was mostly unconscious throughout. Had a laugh and a smile, but was definitely having periods of decreased oxygen levels, and we intubated him quite quickly on arrival to maintain his airway until donation could proceed. So he spent a couple of days in ICU. The first day he was very comfortable, sedated. We got his second kidney accepted. We did repeat CT chest, abdo, pelvis, just to check if there was any progression of his disease or any further malignancies that hadn't been found months earlier, and there wasn't. We did unfortunately find some PEs on a chest CT, and so his lungs were declined at that point. On day 2 of his admission to ICU, we withdrew care with his family present that morning, and he died very quickly and went on to donate. So really, and again, another great outcome, and he was able to donate his left and right kidney, and both those recipients are doing really well, and also 2 corneas were retrieved and also have both been transplanted and restored sight to 2 people. So really great outcome for him and his family, and for everyone involved. A lot of people often ask what we give the donor families or what our contact is with them after. So the families will receive an outcome letter, and in that is similar information to what I've given to you on the slides on how the recipients are going, where they're at, a little bit of really de-identified information about their lives, as well as they get bereavement packs and grief support. We have our donor family support coordinator, Michelle Skinner, who contacts all our families, and she can offer ongoing counselling if they require, as well as she can help them, refer them on to other services if they need. So the donor families and recipients can also correspond to each other in a de-identified fashion. So it's all very good. We also offer items of remembrance, such as handprints and hair locks and other things that the families may like. And I think that's it, actually. Yes, it is.
Thank you very much, Jo. Now over to our audience. We don't have any questions in the chat yet, so please do add anything in the Q&A box that you might like to ask Jo, and I can ask Jo on your behalf. Jo, I was just interested, obviously it's really important to take that first step to have people on the organ donation register. If someone is listening and is interested in doing this or finding out more information or sharing that information with friends and family, what would you suggest? What are the next steps?
Yeah, so you can register on the Medicare website. And on there's lots of information. There's also just the Donate Life Victoria website, and they also have lots of information. And they definitely also produce donation information in other languages as well. So if you've got people that English isn't their first language, you're able to print that out and give that information to them as well. But the registration's all done by the Medicare website now.
Excellent. Thanks, Jo. And it sounds like you work quite collaboratively at times with the palliative care teams. I just wondered if you could expand on sort of what those key sort of times in that journey are where you would be kind of working alongside with the palliative care team or kind of liaising with them and how that happens.
Yeah, absolutely. So normally what's happened is, sorry, another code. Normally just someone will reach out to us either via, so Donate Life have a 24-hour pager that people can contact, and then they'll either speak to me or one of my colleagues, or people will phone me or email me directly, and we just normally chat through. So the times are often when someone's maybe mentioned they want to be an organ donor, and either the GP, palliative care physicians, advanced care planning team will contact me. Sometimes we can have a really brief chat and rule someone in or out. And other times, we'll organise to meet again. And it just depends on the patient, where they're at, I guess, in their stage of their palliative care, and what the next steps are for them.
I can imagine every scenario is a little bit different, just depending on and sort of what's happening and who's involved.
Yeah, absolutely. And sometimes it's just whoever is making the referral is just they just want some more information on what to give to their patient, and especially explaining that for organ donation that they'll have to come to the hospital. I think obviously for a lot of people that's just isn't in line with their end of life wishes, and I think that's really important. That's okay. We want the best for them at this time. So
that's right. Great. Thank you, Jo. Then my last question was just wondering if there's been any particular, highlights in your role, really sort of special moments or scenarios that you've been involved in. So it's pretty incredible work that you do.
Yeah. I think it's one of those roles who people often say, I don't know how you do it. Like, how do you just deal with death and dying all the time? Probably much like yourselves. But we really have the absolute privilege to meet with families who despite their grief, can think of other people. And I think that's a really amazing thing to be able to witness, is people taking their grief and turning it into something else, and being willing to be selfless and think of others and save lives. And definitely the first person consents. So yeah, the patient's donating after voluntary assisted dying or other ways has been that's been a real honor. We don't often get to meet the people that are donating. We spend time with their families, but not the actual donor themselves. So to know the comfort it's actually bringing them as well is very helpful for us to know that, that this is a good thing that we're doing.
Great work, Jo. Jo, we've got a couple of questions that have popped into the chat.
Yep.
One is, do families ever get to meet the donor recipients?
No, no, not in Australia. They shouldn't. Well, they shouldn't, because it's all anonymous, so no one knows who their donor or recipient is. In saying that, social media, a lot of people will somehow figure it out, especially if there's been a case that's been in the media, and they'll figure out the timeline. So people do, but they're not. We can't introduce them. Yeah.
Thank you. And the other question is, can you speak to tissue donation specifically? Is there anything else you can tell us about tissue donation?
Yeah, absolutely. It's a great question. So for a lot of the patients that can't be solid organ donors, they can potentially be a tissue and eye donor. Tissue and eye donation can occur up to 24 hours after death. So the patient doesn't have to be in the hospital as well. They can pass away at home and still become a donor. The tissue and eye banks tend to have a much more stringent policies around what they will and won't accept. And unfortunately, for our patients with cancers and neurological things such as your Parkinson's, your motor neurone, they won't accept, unfortunately, at this point. But I always say, don't be afraid to call. We always ask the questions. Even though I know the answer's no, I still ask, because things change quite often. So, but it does. It's nice to have that to fall back on, I think, if solid organ donation isn't an option.
Yes. Yeah. Great. Well, thank you very much, Jo. I can't see any other questions popping into the chat. To our audience, now's your last chance if you wanted to pop one in there. Otherwise, please, everyone, take the time to complete the participant evaluation survey via this QR code on the screen. There's also a link in the chat, and I believe it will pop up at the end of this webinar too. So lots of opportunities to jump on and complete our evaluation. Thank you very much. So I'd just really like to thank you, Jo, very much for presenting our webinar today and just sharing your time and your expertise with us. It's been really informative, and I'd like to thank our audience as well for taking the time to join our webinar today. And that brings us to a close. Thank you, everyone.
Thank you very much.